Let's talk about how Department of Education can support school districts, particularly around behavioral health concerns. And to discuss this, I'm so glad to have with us Scott Hutchins and Mike Leathead. They are from Michigan Department of Education, and they have done some really innovative things to support school districts around behavioral health. So Scott and Mike, I'm really glad to have you with me.
Thanks for having us.
Yeah, and I was really impressed when I went to Michigan Department of Education website to see the resource page that you have for school districts around behavioral health. You provide a lot of really interesting resources, and kind of being a place to bring those resources together to make them accessible to schools is really fantastic. So I was wondering if you could just start by sharing what you saw is the need, and have the needs shifted, and how the Department of Education has pivoted to meet those needs.
Yeah, I think we'll start off with just kind of a little historical perspective. At the end of the 2018 election season, there was a committee that had been working together to look at school safety, and one of their focuses initially was primarily on looking more at the hardening of schools, so addressing bulletproofing the glass or making entrances more restrictive so that just anyone can't walk into a school without checking in first. And as I said, that was kind of the primary focus in the beginning, was looking at how can we fund a hardening of schools. And as this committee met, they kind of shifted their focus from more of a approach of hardening to how do we actually address what the needs of the students are and why they're actually hurting themselves and hurting other people. And so they wanted to instead look at more investing in a behavioral health model for schools. How do we meet students where they're at? How do we reduce some of those barriers that are making it challenging for students to get access to services? And so they passed some funding within the legislation to add school-based behavioral health providers directly in schools, so that again they could start meeting the needs of the students and identifying again why are they hurting themselves and why are they hurting others. And that's evolved over these past few years into now we've got both budgets available for hiring behavioral health providers in schools, but also looking at school safety funding as well. So that kind of gives you like a historical perspective of where we've been in the past 5 years.
Yeah, that helps a lot. And I have a couple follow-up questions about that. One is going from, hardening the schools to create safety versus meeting the needs of students so that those aren't an issue in the first place. Was that based upon research data? Or like how did they determine what's actually going to be effective in regards to the strategy with that?
Mike, you want to take that one?
Yeah. And so, yes, this commission or this group, right, that was really tasked with coming up with recommendations. Yeah, there was definitely research that they looked into regarding that, and really the looking upstream and saying, okay, so yes, hardening schools is a piece of safety for students, but let's take a look at what might be driving those decisions to do something that obviously puts safety of everyone in danger. And so, yes, they recognize that. Let's go upstream and try to get the students some of the learning, right, about self-regulation and all of those pieces. The adults that interact with the school-age youth, let's get them some training to recognize potential concerns. So it was good that they said, let's take a few steps back from all of that. Mm-hmm. School hardening is one piece, but let's look at the other pieces.
I see. So so research shows that both are important. It sounds like. Is that right? Yeah.
Oh, like yeah.
Yeah. And in terms of
people think, people think that school hardening is, the bulletproof glass. It's not just about those pieces. It's how many entry points do you have, and are they actually locked, that aren't really anyone's really keeping an eye on, right? Those entrances and exits of the
Mhm.
buildings. And so just that thought process around it of, let's make sure those other ancillary exterior doors are locked at all times, and we have basically one entry point.
Yeah, yep, that makes sense. And I experience that when I go to schools, the one entry point, you got to check in and so forth. Yeah. And as a parent, it does make me feel more secure knowing that that's a situation rather than just, hey, people could come and go as they wish. Now when school's out, it seems like it changes a bit. Like for the activities after school, it seems like at least the schools that my kids are at, things are kind of more open. In terms of the behavioral health counselors or specialists or resource professionals at the schools, what specifically is their role? Like, do they provide psychotherapy, or is it more of psychoeducation and kind of screening for needs and referring students out for counseling?
I'd say all of the above. So depending on the behavioral health program at the intermediate school district and what the resources are that they have available to them.
Mhm.
Initially, there was a lot of focus on the mild to moderate needs. So there was some type of psychotherapy, as you mentioned. There sometimes was just kind of some check-ins, see how the students were doing, maybe getting them connected to services within the community mental health, if those resources were available. It's kind of evolved. We're on 5 consecutive years now of funding for this. As I said, depending on the community, where some have very limited resources outside of those school-based providers, so they will do some more of that intensive psychotherapy within the school setting. Other ones will do more of, again, kind of a check-in, check-out with those students, get them connected if they are, a CMH within the community or a child mental health center or a hospital, to get them connected. Also, as you said, screening has increased dramatically. One of the big key pieces with screening is having the ability to get those students connected to the resources that they need as a result of that screen. So again, figuring out, is this a tier 1 universal type intervention? Perhaps we're getting a lot of students that are screening for anxiety, and maybe they can look at implementing some classroom lessons or whole group lessons that address anxiety as a whole. And then getting down to that tier 2, tier 3 level, we're actually finding students not just showing signs of anxiety, but actually it's affecting their academics. And so maybe those are the types of students that maybe get that tier 3 one-on-one intervention, because they're starting to see an impact within the classroom. So again, I would say it's definitely all of the above. And as again, we're going on 5 consecutive years of this funding, we are starting to see that evolve, and people are really starting to look at a comprehensive behavioral health program, where initially I think it was almost like more of a triage and just trying to figure out, okay, how do we start building caseloads and get some of our most immediate need students some type of services. And now I think we're starting to see that shift where they're doing that, plus also trying to look at some of those universal interventions that they can have.
Yeah, in Michigan, do some of the school districts also use online therapy, like a telehealth service provider?
So yeah, we have seen some have contracted with behavioral health providers through telehealth. In particular, more of our remote areas. For example, I know that there were some ISDs that were looking into in the UP area, trying to get some of their students connected through telehealth. The challenge is coming up with, how do you make sure that you get that student from their classroom, to a private setting where they can meet virtually with someone, and then make sure that you get that student returning to the classroom safely. Because again, if you don't have that trusted adult necessarily right there with them. Mike, are you familiar with any of your Project Aware sites that have actually implemented telehealth
Yeah, thanks, Scott. And so what Scott's referring to is a federal grant from the Substance Abuse and Mental Health Services Administration. It's called Project Aware, Advancing Wellness, right, and Resiliency in Education. And there, it's been very limited. I think at the beginning there was hope that there would be more telehealth happening, but for those same reasons, Scott, is that the two ISDs, that the two intermediate school districts that we're working with in the Upper Peninsula, very rural, and so they don't have as many adults, right? They don't have as many providers in some of the school districts to be able to make sure that the students are safe going to and coming from, and some of their buildings are pretty limited in terms of having that confidential space where those students can meet with providers. It did happen a little more frequently during the pandemic to make sure that kids were getting some services, but it's not as streamlined as we had hoped, because you have to do different agreements, right? And making sure that yeah, when you're talking about the video and making sure that link is secure, all of that. So it hasn't been as straightforward as we once had thought.
Yeah. And out of curiosity, do any of the schools use text-based counseling? Because kids love to just message each other back and forth. And it's also private. Like, they don't need to be in a private location. They could be anywhere sitting at their desk because no one can hear the conversation. And messaging back and forth with a counselor?
I know that there were at least one, if not two, vendors that came, especially during the pandemic, as Mike alluded to before. And I don't know if we've got any specific districts or intermediate districts that took advantage of that technology. So I know that there are, like I said, a couple of text-based vendors that provide a HIPAA FERPA compliant, as you said, Ray, an appropriate way to interact with that student. But I'm not familiar with any districts in Michigan. I don't know if you are, Mike.
Well, not necessarily specific districts, but statewide. So federally, there's the 988 hotline. And so that is instead of calling 911, right, for more of a physical emergency, okay, if we're having a crisis with our emotions, right, 988. So, and actually just prior to that coming to fruition, the state of Michigan passed a piece of legislation around, and it's called MyCal, it's the Michigan Crisis and Access Line. And so we were already establishing a way to text, and it's 741-741. And so yes, there is a mechanism for students to be able to text that to at least start off the conversation. Now, then the counselor that is responding on the other side might say, okay, let's do something further. Maybe it is a video, or at least they're connecting with the services rate in the community where that student is, and so they can get them connected, and doing more of a warm handoff on that. So it started off as more of a warm line instead of a hot line in a sense. So yes, students can text and be connected with someone, and then that might lead to then the student entering in more official services.
Yeah. The MyCal and the 988 is kind of like the screening and referral and support during kind of a acute situation. But yeah, I think a lot of kids like the text space for actual therapy. So it'd be interesting to see if schools start utilizing that. And then also applications. Because again, that way they don't have to go to like a counseling office and be identified as going to counseling and have to find a secure location, a private location, all that kind of stuff. So another thing that you all have done a lot of work on is working with the Health Information Exchange in Michigan. So one of the big struggles, so health information exchanges, for those of you listening, the goal had a healthcare strategic plan for a long time where there'd be a federal health information exchange. It's basically a one warehouse where all health data throughout the nation goes and lives, so that any healthcare provider seeing a patient can access that health information exchange federally and acquire all of the pertinent healthcare information that they would need to know to provide services to that patient. It is fantastic for care coordination, for efficiency, for safety, for eliminating medical errors and all sorts of things. But a lot of states have implemented health information exchanges. We don't have a federal one yet, but a lot of states have ones. But behavioral health has been excluded from that. And there's a lot of challenges with having behavioral health and also substance use disorder treatment records being put on the health information exchanges, particularly around privacy and determining who has access to the information, and then putting power in the hands of the patient themselves to determine who gets access to their records, et cetera. So it's been a really big challenge, something that needs to be taken on. And it sounds like you all have taken that on to quite a big extent. So can you speak to that? What the need was and what you all have done with that?
Sure. So as you said, we're partnering the Department of Education, the Department of Health and Human Services. We're partnering on a project with MyHIN, the Michigan Health Information Network, that's partially funded by an advanced planning document from the Centers for Medicare and Medicaid Services, or CMS, to get our school-based providers, as you mentioned, Ray, with an active care relationship. So there's two real critical pieces to make this work. One is that active care relationship, and the second thing is obviously having the right permissions. So as you said, Ray, right now, we've got a disconnect with school-based providers being able to have access to a lot of that other health information that may impact the student that they're working with. And so we're working with, as I said, MyHIN through this project. We literally got the go ahead to start this project on October 1st. And so we're talking 16 days. We've had 2 informal meetings to get things started. We're currently looking to grow our partners and find some demonstration sites. One of the key things that we're going to start with is kind of like sandbox data. So not legitimate students, but pretend data that our behavioral health providers that are based in the schools can start looking at to determine, because one of the things they need to figure out with MyHIN, as you mentioned, Ray, there's all kinds of information that can be stored within that electronic health record. And so what we don't want to do is overwhelm school-based providers with more information than what they need. So for example, it may benefit a behavioral health provider to know if a student was hospitalized for a short period of time for suicide ideation, but it's not going to be meaningful for them to know that they had a teeth cleaning the week before. So looking at what data is available and then we've got to figure out, excuse me, again, how do we get that information from the Michigan Health Information Network to the school-based provider? So we have another partner that's part of this, which is called MD Logics, and they have a virtual care platform called BH Works. And so we're working with our partners at MD Logics to create that single sign-on. So when a school-based provider signs in to BH Works, again, if they have an active care relationship with a student and that student's parent or guardian, or if it's a student who's old enough to give their own permissions, if those permissions exist and if that provider has an active care relationship, what type of information can they have access to within MyHIN that would help them as they're working with that student that they have an active care relationship for? I would say this is probably something that could take anywhere from 3 to 5 years to be fully ready. Obviously, again, we've got to figure out what is the right data to share. You've got, when you're talking about school-based providers and you're talking about health information, you're blending HIPAA and FERPA in some cases. So a lot of details still need to be worked out. But as I said, we've got some great partners. We've got some support from Department of Education, Department of Health and Human Services financially, and along with those funds from the Centers for Medicare and Medicaid Services to start this project and really start building it with, again, in the beginning, some kind of sandbox data. From there, we'll look at some demonstration sites, and then hopefully eventually this is something that would take on across the state.
Yeah.
The other thing I would just add is just that, to our knowledge, Michigan is the only ones that are currently working on this, the only state that's working on this. We have reached out to our partners. It's called the Healthy Schools Promising Futures, which is several states that expanded their Medicaid programs like Michigan did. And again, to our knowledge, Michigan is the only or one of the very first states that are trying to look at this type of project. So a lot of it's going to be, done from the beginning, from scratch.
Yeah. And another thing that HIEs are really good about is the registries, to be able to do some good data analysis. So like going back to the first question of, well, where's the data that says, hardening schools is effective or more so effective than, addressing behavioral health needs of the students, or what is effective there? And I know as a nation, when it comes to like gun violence, that is a place where a lot of research needs to be done. People kind of make assumptions on what's going to be helpful, and it's not backed up by solid data. So having health information exchanges where we gather data from around the nation through registries, we can analyze that data to see what are the needs and what is truly effective. So what's making this particular school so effective? And if we don't have the data in a consolidated place, we can't do that analysis. So that's another way I think this can be really helpful. Has there been discussion on that in terms of the data analysis piece of that, or research that is wanting to be done?
Yeah, absolutely. So there's a lot of partners that are very interested in this project, especially university partners, as you said, that are looking to do that research. And again, because we have the right partners, I feel, at the table, I think, Ray, we're in a very good position to do that, because again, with BHWorks being able to store that data and again, start looking at what are the reasons for referrals. Are we seeing high numbers of anxiety or substance use disorder, depression, things like that? So yeah, I would 100% agree with you that there is a not only a need for that, but there's also an interest from several partners that are looking at it. And again, just to kind of go back to that point we talked about in the beginning of this conversation, is the devil's in the details, right? So it comes down to making sure that we have the right permissions. Are those active care relationships in place? Because one of the pieces that's critical with the Michigan Health Information Network is that, again, a school-based provider with an active care relationship has access to certain data with the right permissions, but those personal notes for that student aren't being shared to MyHIN, right? So they still have that privacy and they still have that confidentiality piece that's critical. And again, so when we're talking about data and research, I just want to make sure to clarify that doesn't mean that, confidential information on that student is going to be shared through the MyHIN, but we will be able to have some of that more universal community-wide data, as you talked about, Ray. Why are students coming in for referrals, and how are schools being successful treating high numbers of students with maybe anxiety or depression?
Yeah. And historically, one of the, questions was, you have health information exchanges, and usually it's the healthcare providers that control the data with those. And then you have personal health records where the patient controls the data. So the patient determines who gets access to the data and what they get access to and what's on there and all that kind of stuff. So I know that there's kind of movement towards like giving more and more power to the patient over their records. So has there been discussion that like and with the schools, it would be the parent, and that's where it gets even more complicated. Do you want the parent seeing all of the child's data, and what data? But is there discussion on the parent having control over, what data is disclosed and what data is not disclosed?
Yeah, the parents, they drive the bus on that, right? And so
Mhm.
it's also taking a look at even those disclosures, right? And what they're signing off on what data are they allowing and which entity to see the data, and being more specific instead of trying to do these blanket, oh yeah, release of information pieces. So the other part of all of this though is also mm, uh, there's a few layers to this, is that one, being able to inform the parents of how might this sharing of information be beneficial to the parent, but then also their child. And this coordination of care that you talked about, Ray, too, is very important to really look at the whole child. And so there's that piece, but then there's also, and we know this in other states as well, is really follow through in terms of parents and their trust with health information, or just their schools or the state education authority, right? That they see, okay, this information was protected. Nothing was leaked on anything. The right people had the right information. They didn't have more than they should have. They didn't, and less than they should have. And so the more that we can show parents that they can trust that process, I think that'll help more parents sign those releases of information.
Yeah, but will the parents have a login to
Oh,
the health information exchange? Because it's very different to say, hey, here's
yeah,
a form for you to sign off on. That's very different. And don't worry, we'll take care of it.
yeah,
We'll log in and we'll manage it, but you sign this paper. Versus them being able to log in and actively see who has access to what, who gets access to what.
mm,
Yeah,
It's
and I
probably
think
not.
that's where I said before, we're looking at this could be a 3 to 5 year project, because I mean, those are the kind of questions, right, that we don't have answers to yet, but we need to have those important discussions, because it's not my understanding that a parent would be able to have a sign on to be able to access that information. I know that that currently doesn't exist, but again, going forward, maybe that is another layer that could be a possibility. But again, that's why we're looking at, a 3 to 5 year project, because those are the exact kind of questions that we need to figure out and provide answers to, and we don't have them yet.
Yeah. So if say I was making decisions for a Department of Education in a particular state, should I just wait for Michigan to get these wrinkles ironed out and get it figured out and then implement something like this? Or should another state also be working on this effort, at the same time?
Yeah, I mean, we would love to have partners on this. As I mentioned before, we reached out to the Healthy Schools Promising Future. And to our knowledge, as I said, there aren't states right now that are chomping at the bit to get started, but I would love to have thought partners in this. It's definitely, like I said, not something that, and I feel like each time, even like with this conversation with you, Ray, I feel like each time we talk more about this, we get more questions. And that's exactly why, we're starting with a project that, again, is not based on actual students. It's that sandbox data that I talked about, because I think this is going to be one of those projects that might be 1 or 2 steps forward at a time and then 1 or 2 steps back, right? It's like, okay, we didn't anticipate this, so we've got to take a step back, and look at. So no, I would love if other states were interested in joining forces and being partners and thought partners with us on this, because we do want to. I mean, the ultimate goal is obviously protecting our students and improving their behavioral and social and mental health outcomes, right? But we also want to do something that's replicated by other states. I mean, ultimately, we don't want just this to be a Michigan thing. We want this to be something that I said would improve the care of all students going forward.
Yeah, I love the idea of doing the pilot with the sandbox, because I see so many telehealth programs, and I know this isn't necessarily a telehealth program, but in my world, telehealth, I see a lot of telehealth programs just launched, and they're clunky, they're messed up, people don't know what they're doing, but they just want to get it out there quickly. So you're taking a very careful approach, which I really value that. I wonder if the fear of litigation plays a big piece in taking so long and being so careful. Is that the case? I mean, you obviously want to protect the end user, the student, but also there's the possibility of litigation with such a thing.
Oh, absolutely. And okay, substance use. There's 42 CFR. That's federal regulations on substance use, and so you have to make sure that you're following those type of federal regulations. The state has their own legislation in place on pieces, so it'll have to be slow. The last thing you would want is then the safety of the kid, the information for that kid and or adult, if we're even talking about this whole entire health information exchange, but it's the safety of the individual, regardless of whether litigation because didn't meet a federal regulation, all of that. It's making sure people are protected and they can trust what we're trying to do. And so that has to be a slow process and well thought out process.
Yeah, and maybe the last thing we'll mention or talk about is I think that with a lot of school districts, one of the challenges with behavioral health services is they refer the students out to a provider, but then where's the care coordination? Where's the sharing of information? They usually do not have technology that they're both using to share information to get the follow-up. Like, how's the student doing? Are they going to their appointments? Are there particular needs that us as a school ought to know about? Are there things that us schools know about that the provider ought to know about? Like, the shared information, there's usually a lot of times what I hear is that it happens over a phone call, which means people have to remember to make that phone call and try to get, so having something like this where the providers in the state have access, the schools have access, et cetera, really helps with that care coordination piece. Yeah. Excellent. Well, thank you guys so much. I love the work that you're doing. I hope that we get an update. We'll have to check in like a year, because I know other school departments of education will definitely want to know about this. So thanks so much.
Thank you, Ray.
Thank you, Ray.